Everyone, I'm Maury Planbeck from the Indianapolis Neighborhood Resource Center. Thank you for joining our first evening of Neighbor Power Indy 2021. You will all notice, except for me and Jay, the speaker, you will not be able to talk now during the presentation, but you can ask questions, ideally from the Q&A section. If you look at the right of your screen, you'll say chat, participants, and Q&A. If you put them in Q&A, that will work a lot better for our speaker. And I am going to introduce him. His name is Jay Foster. He's a healthcare chaplain and chaplain educator who is now serving as Vice President for Spiritual Care and Congressional Partnerships with IU Health. So Jay, if you would turn on your camera and your mic, and you're ready to go.
Thanks so much, Maury. It really is good to be with everybody tonight. I will say one small correction. It's not congregational. It's not congressional partnerships. I think that's Mitch McConnell's job. That's a little bad humor. It's congregational partnerships. I was a healthcare chaplain for 30 years at Wake Forest Baptist Health in Winston-Salem, North Carolina. And there I did some work partnering with congregations to address social determinants of health. And so IU Health invited me to come here and launch a similar program. And that's what I'm excited to share with you tonight. So if you don't mind, I'm going to use a PowerPoint to help guide the conversation. And I'm trusting that people can see that well. So again, it's just really good to be with you tonight. I appreciate the invitation from Maury so much. I've titled this talk, and it's not original to me, An Epidemic of Loneliness. And I'm going to say, of course, a lot more about that. Here's the things I'd like to cover tonight. I'd like to talk a little bit about how loneliness and social isolation is more than a difficult mood. It can have a tremendous debilitating effect on our psyche, our body, and our spirit. And I think one thing the pandemic has made clear to everybody is how difficult social isolation can be. I'm going to talk a little bit about current strategies of health systems across the country that are partnering with congregations and other faith-based groups to address social determinants of health, and then talk about how we at IU Health said, well, let's start by addressing these issues of loneliness and social isolation, and have a pilot project on that with 12 congregations now in Marion County and 2 down in Bloomington. But first, let me define some terms. What do we mean by spiritual care? Spirituality is defined here, and I won't read the definition to you, is defined by professional spiritual care groups like the Association of Professional Chaplains. The idea is that human people, we need to make sense of things. We need for life to cohere in some meaningful way and for our life to have purpose. And chances are, if you are ill or have experienced a trauma, then that sense of meaning and purpose has been impinged upon. And so for the many years of my career, it's been really kind of a joy to meet people of all faiths or of no faith, usually at the bedside, sometimes the emergency room, and just walk with persons as they're trying to make sense of what's happened to them. So spirituality includes things like beliefs and values and traditions and practices. But it's important to note that while I think all religions across the world are expressions of spirituality, and let me just add, it's kind of amazing how many beautiful expressions there are. It's also important to note that spirituality is not necessarily limited to any one set of religious beliefs or any religious belief at all. So I think, as most persons may know, that more people these days are identifying as spiritual but not religious, or none of the above, right, than almost any other category. But what do we mean by social isolation and loneliness? And again, I've thrown up on the screen there some sort of formal definitions. Informally, social isolation is what it sounds like. It is to be cut off from other persons. Importantly, one can be fairly socially isolated and not be lonely, right? And one can be in a crowded room, as you might imagine, and still experience great loneliness, or have a lot of family or friends around, but still experience loneliness. One thing that's interesting that I'll come back to later is that both kind of conditions, if you will, both states of being can have a negative impact on faith, on your health. So you can be socially isolated, not feel lonely, but that still can have a sort of deleterious effect on your health. I'm helped in this reading, in this work, by the work of Dr. Vivek Murthy. And you may have heard his name recently because he's heading up the efforts to deal with the pandemic for the Biden administration. In his first term as Surgeon General under President Barack Obama, Dr. Murthy wrote a book called Together, The Healing Power of Human Connection in a Sometimes Lonely World. And Dr. Murthy, I've commended the book to you. It's a great read, easy to read, and explains this condition well. And he made loneliness during his first term as Surgeon General the major social determinant of health he wanted to address, because in his work as a physician, he found out how many times people at the bedside were suffering and continued to suffer as they went home because they didn't have persons to walk alongside them when their illness. And that this had a pretty terrible effect on their health. One of the earlier researchers in this field, Dr. John, and I'm not going to do justice to the name, Cacioppa, and this researcher pointed out that that loneliness, like many other predictors in our human psyche, is a factor of evolution. And so, we get hungry, and that's a sign to us that we need to go find some food. Loneliness functions like hunger or thirst. It's a signal that there's a threat to our belonging, because we as human people have learned to evolve by working as one social group. And if we're cut off from that social group, that's an actual threat to our very being. And I guess it's obvious in our current environment that we move so fast, and we live in increasingly sort of nuclear family settings, or lots of folks living by themselves, or only one or two other persons in their household. And that this is a very different thing than how we've evolved. Hundreds of years ago, or even 50 years ago, we were much more likely to be in a large family group, social group, community group, where we really knew our neighbors, and where the sense of working all the time was not such a driving force in our world. I guess with COVID, we're getting a crash course in this lesson about loneliness as a public health crisis. And we're learning how interconnected all these public health crises are. So social isolation complicates loneliness. Loneliness intersects with mental health crises and substance use disorder. All of these problems are interwoven with and complicated by economic and food insecurity, precarious housing. And so, you sort of pull at any one thread of the spider web, and it all shakes. All of those public health crises interwoven. So I've said a little bit about loneliness and social isolation having an impact on health. This research showed up actually in the AARP magazine, is where I saw it for the first time. And I won't go, it's a kind of a busy slide. I won't go over all of it, but I just highlight a couple of factors. So if you're lonely, if you identify as lonely or isolated over a period of time, that has the same health effect as if you smoked 15 cigarettes a day. Interestingly enough, persons in excellent health, about 25%, almost 1 out of 4 identifies as lonely some or a lot of the time. But if you look at that sort of middle slide there, if someone is considered to be in poor health, their identification as lonely jumps up to almost 1 out of 4, almost 75% of the time. Loneliness, isolation correlates with certain other disorders, diabetes, depression, anxiety, and the amount of money that is lost every year to loneliness and isolation is just staggering. And it's important to, I won't dwell on this for long, but just I work for a large healthcare system, and it's important to note, I think, as many of us know around already in the room, that U.S. Devotes just lots of money to healthcare spending, almost twice what's spent in wealthier countries, in other wealthy countries. But our health outcomes are not really any better. And we actually spend more on administrative costs and less on long-term health care than other countries sort of in our demographic. One way I heard it described by a health researcher is this: for every dollar that is spent on acute inpatient care in, say, in the European Union, $2 is spent on pre and post care in the community, preventative care and post-operative care to help people recover after they get home. In the United States, that figure is 50 cents on pre and post care to every dollar spent in acute care setting. So I think one thing the pandemic has made clear is how much we've sort of lost by not having a more robust and integrated public healthcare system. So I've talked a lot about social determinants of health, and I'm guessing most people on the line have heard this phrase and may have a pretty good understanding of it. I find this slide pretty helpful to help explain social determinants of health. So I put it this way, that research shows that about 20%, the good health outcomes correlates about 20% of the time to having access to really good clinical care, like you would get at IU Health or Eskenazi or Community or Ascension or Franciscan. But the majority of the health outcomes correlates to other things, and it makes sense when you think about it. About 30% of that correlates to our behaviors. Do I smoke? Do I drink to excess? Do I exercise well or not so much? And also to social and economic forces. Do I have access to good and healthy food? Do I have enough of an income that I'm not, sort of worried all the time that I'm going to lose my place to live? Or in fact, am I housing insecure? And about 10% of it is environmental factors. And here in Indianapolis, we hear a lot about lead, for instance, and those other kinds of toxicities that can impact things. So one of the reasons that I was really excited to come to IU Health is that this health system, like many health systems, has recognized that to really improve the health of our community, to really make Indiana one of the healthiest states in the country, we need to push good health care way upstream in the community. Lots of effort on wellness and on community life. And so that's part of what we're all talking about tonight, thanks to Mari for for the work of NPI in this conference. I'd like to quote my former boss. So I learned a lot, just a little bit about me. So as I said, I was a healthcare chaplain and chaplain educator for about 20 years at Wake Forest Baptist Health in Winston-Salem, North Carolina. And Wake Forest hired as a new leader a guy named Gary Gunderson. And Gary is a public health scientist and Methodist pastor who had been working first for the Carter Center, working in the area of food insecurity and congregational life. And he got invited to go to Methodist Le Bon Hur, which is a big healthcare system in Memphis, Tennessee, to try to develop this idea of partnering with congregations to address social determinants of health. And Gary would make the point, I would make the point, this is not a new idea. There's nothing new under the sun, right? You've heard that Bible verse. And there's a long tradition of health systems connected with the mission of faith tradition. So I'm sitting tonight at Methodist Hospital, and Methodist Hospital was built in, I think, 1860s and founded as a deaconess institute. And part of its charter is to work with congregations to provide care, the best of medical care, and especially to persons who are having a hard time affording it. So this is not a new idea. But Gary is a wonderful guy and turns a phrase pretty well. And Gary said, proactive mercy is cheaper and smarter than reactive charity. And meaning by that our health system and lots of and other health systems have devoted and have to, as part of their as part of our institutional foundation with CMS, have to demonstrate our benefit to the community every year, and we work hard to try to do that well. But lots of health systems, actually IU Health doesn't do this. Lots of health systems count the cost of that community benefit as medical bills that never get paid that we end up sort of eating. So Gary says, if we could take some of that money and invest that in working with congregations and lots of other ways to get health into the community, that's going to get us a long way down the road. So IU Health is not alone in this effort to work with congregations and other faith-based communities to improve healthcare. There's lots of work about this. There's a great group called Stakeholder Health that includes, it's a consortium learning community of about 35 healthcare institutions across the country, including, back up a slide, Adventist Healthcare Systems out of Loma Linda, Barnes Jewish, Baylor Scott White, Big Trinity Health System, Methodist Le Bon Hur, Wake Forest Baptist Health, just to name a few, all of whom are trying different models to think about, well, how can we be smart with our mercy? How can we use our dollars in the very best way to provide good health care? And so several of those models, one of them is that Gary helped to get on the map at Methodist Le Bon Hur, used a patient navigator model. And I won't spend a lot of time on this, but just to give you a taste of this, here's where someone would be employed by the hospital to be a patient navigator. But while they were employed by the hospital, they'd really work with 5 or 6 or 7 congregations to be close partners with that congregations to help that patient when that patient returned home to navigate and get back on their feet and get towards wellness. And about that group began with 12 congregations who all sat around a table for about a year before they ever saw the first patient and said, how can we trust each other? How can we develop a really good, strong, flat partnership with ourselves and with this healthcare system, so that we really are working closely together. Because part of the idea of this is that healthcare systems know an awful lot about medical care, and congregations are wise and know a lot about their own communities. And so if the healthcare system can go to that congregation and learn from them their wisdom about what are their assets in that community and what are the barriers to healthcare, then we can work together on that. So another model out of Wake Forest, where I came from, included 2 or 3 initiatives. One is the connector model, and I'm going to talk a lot about that in a minute. Another is a community health worker model, and this is someone who works in the community closely with persons. And then chaplain specialists, and that would be persons who have training like mine as a healthcare chaplain, but their post is not in a healthcare system, but say at a homeless shelter, like Wheeler Mission, or at other community health kinds of settings. I want to say just a little bit about leading causes of life, and quote my boss, Gary Gunderson, again, just one more time. We've used this phrase, social determinants of health, and it's a really wonderful phrase for and concept for public health sciences, but it's a little bit limiting in terms of theology. It's kind of bad theology. We would never want to say that one zip code is limiting their capacity or ability to live richly or fully into their spiritual life. In fact, the opposite. And so Gary wrote a book called Religion in the Life of the Public, where his point is where we find these things: connection, coherence, agency, generativity, hope. Where we find these things, these are the things that are not leading causes of death, but they're leading causes of life. And if we can join with congregations, join with communities, and learn from them how they are leading towards life, and join that effort, we'll have a rich and full partnership. So I was asked, as I said, to come to IU Health and begin to think, well, if we're going to work smartly in the community on social determinants of health, where might we start with that work? Frederick Buechner may be known to some of you. He's a Presbyterian minister who wrote a lot about the idea of calling or vocation. And he had a phrase I like: we know what our calling is in the world, our purpose is in the world, where our gifts meets the world's particular needs. So as I thought about where IU Health's spiritual care chaplaincy department might make a contribution, I thought, well, perhaps we could focus first on this idea of social isolation and loneliness. Why? Well, because healthcare chaplains know a lot about walking with people on difficult days in their life. And I'll just say, I won't assume that everybody knows what a healthcare chaplain is, so I'll take just a moment to explain that. Healthcare chaplains are persons who have been recognized by their own faith tradition as a clergy person or as a religious leader within that group, and have been ordained or similarly set aside for that ministry, and have completed usually a master's level or beyond level of training, and then 1 to 2 to 3 years of residency in a healthcare setting to learn how to walk alongside persons of all faiths or of no faith as they deal with illness and loss. So chaplains, we come into this work because we love working with people. and finding out how they are making sense of the world, how their spirit is helping them to cope with the challenges that are right in front of them. And it's really kind of a privilege to walk with people at that moment in their lives. So we know a little bit about this, and maybe we could help with that. And congregations know a lot about caring for persons who are what we used to in North Carolina call the sick and the shut-in. So most congregations of all faiths have a list of persons within their congregation and have an outreach to persons in their neighborhood who are dealing with these things. So the idea was, could we find some congregations that are interested in partnering with us about this? Mind you, when we thought we would start this pilot, we dreamed this up in 2019, and we're all set to launch in about this time last year when the pandemic hit. And so we put this pilot project on hold for a few months as we turned our attention, really fully to the real challenges that were coming in the doors of our hospitals. But in June, we got started again, and we were lucky to hire and find a manager for this project, Shadrach Kamwindo. Shadrach is just a brilliant population health leader in our work, who is a person of deep faith, and he's helping to lead this project. But what we've learned, as I said earlier, that we didn't expect to learn was two things. First, that all of a sudden everybody in the world really knew how difficult it is to be socially isolated. And we also learned that people could figure out how to communicate over things like Remo or Zoom or the telephone to really provide effective care. Because our first model was that we would train church volunteers to go into the homes of persons who were experiencing isolation. Well, clearly that was not a good idea, to go into the homes of persons who had just discharged from the hospital and had a chronic illness. So instead, we've been doing that work by telephone mostly, and I'll tell you a little bit more about that in just a second. So here is kind of a busy slide, but here's really how our program works. So I am gonna go through it in just a little bit of detail. So what we're calling ourselves is the Congregational Care Network, and the idea is to connect patients with right resources at the right time to provide encouragement, support along the way. And so we're collaborating with now 14 congregations, as I said, to provide that care. And each of those congregations recruits a group of about 5 or 6 congregation volunteers. And we call these volunteers connectors. And we call them connectors for 2 reasons. One, we think the idea is to build a connection with the individual who's experiencing loneliness or isolation. So that's number one. They're helping them to connect with that person. And then they're helping that individual to connect with their own spiritual, their own emotional resources, and to cope with the issues they're facing with. And then, and I guess this is an important secondary gain. If I spend an hour listening to you and we really connect, then I'm going to learn all kinds of things. I may learn that you have a problem with transportation, and while you'd like to get to your doctor's appointment, you just don't have a way to get there. Or I may learn that you're food insecure. There's just not enough food in the house, and you're worried about how to feed yourself and maybe your loved one. Maybe I'll learn there's a substance use disorder or a domestic violence problem. So our connectors are trained to help, when they learn about those needs, to help that individual identify a need and a way to meet that need in the community, a resource, and then walk with them to help get in the door of that referral. And I think that's a really important part. a lot of us learn, that there's a good resource, and boy, I'm going to get to it, and we just keep putting it off, right? Even though we know it's good for us, because let's face it, most of us have a little resistance to always doing what's good for us. Well, to have someone who's in our corner, who's encouraging but not pushing us towards that resource, that can be a real help. And then importantly to note, the program is offered at no cost, and people can get out of the program at any time they want. The idea is that we'd make that connection with a person, and then I think I may have a slide that says more about this in a moment. Let me see. Yeah, I'll come back to that in just a second about how that part of the program works. But just to say this about the idea of walking along somebody who is hurting. I have a dear friend who is a church history professor who I first heard this statement from him, and it made a big impact on me. Nothing is more healing than to receive the full attention of another person. Nothing is more healing than I'm listening to you and only you. And so a lot of what we do with our connectors is provide training, and a lot of them already have this training, but we provide some training in how to be a good listener, how to walk alongside somebody, how to have respect, and boundaries and attention. And we do this because we believe that part of the goal of the overall effort of this is to help people navigate the healthcare system to get to the right door at the right time. Too many people come in the door of the emergency room instead of into a primary care doc. Too many people come to the emergency room instead of dealing with a substance use disorder issue. And so if we can build a really loving relationship, help that person identify the right door and the right time to get there, and they're not walking in there alone, we think that can be an effective way to help folks get ready to be treated. Hope that makes some sense. The training model we use for this is called Companionship Training. It's a really wonderful program developed by a group called Pathways out of Seattle, Washington, developed about 20, 30 years ago, originally to work with persons who are living with homelessness, with the experience of homelessness. And as you see from the little stick figures there, the idea is, first of all, I'm going to connect with you. Companionship is first to build that connection. But it's also a mutual process. And the idea is to help, as I connect with you, to help you identify other networks with whom you can connect. And so that the idea is that over a period of time, and what we're trying is for like 6 weeks. So each congregational volunteer agrees to walk alongside somebody for about an hour a week for 6 weeks, with the hope by the end of that time that individual has connected with another group. Maybe they were once a member of another congregation, they've reconnected. We've actually had that happen kind of a lot as we've gotten started. Or they've reconnected with family, or they always had a love for the art, but they never took it up. So they get into an art class. It could be any number of things. So yes, it might be faith-based, and it might be that congregation, but not at all necessarily, because we're working with persons and meeting them where they are and following their interests. I may say this in another slide, I can't remember. Let me go in and say it now. The training process for this is fairly short. We meet with these congregational volunteers for like 90 minutes over 4 weeks and go over this training. And that's really adequate because the concepts behind providing spiritual care, they're not hard to understand or go over. But while they're not hard to understand, they are hard to practice, right? If you've ever really tried to listen to people, they are hard to practice because it turns out humans are pretty complicated. We're pretty complicated people. And so I think that we hope a really critical part of this program is that the The group of 5 connectors in a congregation agrees that each volunteer is going to meet 1 hour a week with an individual who's referred to them, but they're also going to commit to meet a second hour a week with each other to support each other and to keep learning about how to do this listening work. And then one of our staff chaplains is assigned to that group as a content expert. And so we keep learning and growing in that way. And so we really are trying to live out of this model that each group has some interconnected parts. Just a couple more slides, and then we'll open this up to the conversation. Y'all have been kind to listen to me talk this long. Try to get one more slide to move here. This is kind of a busy slide as well, but I think it shows sort of the logic I'm trying to explain here. So the first part of the slide says that somebody arrives at one of the hundreds of doors of IU Health, and as part of that health screening, our social workers, our providers are going to learn all kinds of things, right? And it's an ideal time to make a referral to a group like Congregational Care Network. And that helps the individual because they learned about a resource they might not have even known that they needed. But it also helps, we think, the congregation, because congregations are deeply trusted within their communities, but not everybody's necessarily knocking on the door saying, hey, can I get connected with you? And so if we make that handoff from a trusted healthcare provider to a trusted congregation, that simply helps. So then, the second part is our interventions, is that we provide those hour calls and that listening effort. And then we make referrals to all kinds of beautiful referral networks within the community, because as this whole conference attests, there's just a wealth of resources here in Indianapolis and around the state. And I think a lot of the work is how do we help connect with each other and get the person to the right door at the right time. So here are some of the congregations that we're really proud to be working with, and we're excited to be working with. Most of them are located in right and around the areas where our downtown hospitals in Indianapolis are serving. And as I said, a couple of them are in Bloomington. And the vision for this, I guess I'll say, is we hope that if we have good success with this pilot project, that we will develop these kind of congregations all across the state. And that the IU Health system, we've got 16 hospitals across the state, will serve as sort of a trellis, if you will, for this work to grow. So that, let's say if a patient is up at J Hospital in J County and gets referred to Riley Hospital with a child, for instance, and they're being referred back to J County, but they have a need that they can't meet. Well, maybe the chaplain here can call the chaplain up at that part of the IU Health Network and get connected with a congregation in that neck of the woods. So that's kind of the vision. There are challenges to this work that I don't want to skirt over. And so one of those, any of you in the helping profession, and I'm thinking that's everybody in the room, knows that it can be difficulties to maintain good boundaries and to stay within one's scope of practice. And so we spend a lot of time emphasizing that work in our training with congregations, and that's a flat thing. They also help us to maintain those good boundaries. And we, of course, have very careful boundaries around HIPAA and other privacy regards. A second challenge is just recognizing the sheer complexity of human being and the intersections of faith and loss, of mental and spiritual and physical illness, of despair. That these are difficult issues and not something to be glossed over. And we hope and believe as I said earlier, that capacity to really attend to the person in front of us, that in and of itself is a powerful intervention to help people at least face into those terrible, terrible challenges. And one of those challenges can be, and it's important to note, what I call here church hurt. There's an old saying among ministers from my part of the world in the Carolinas, there's no hurt like church hurt, meaning that sometimes the very place where we go for nurture, that sometimes the theological constructs or a failure of the institution is the source itself of unresolved pain and of trauma. And sometimes that's itself what people need to talk about, and that's not an easy thing. In another presentation I made, I said sort of what is our swim lane, and I won't dwell a lot on that tonight. I'll just say that we are beginning, as I said, at IU Health to work on the social determinant of social isolation and loneliness. But should we, because that's kind of our swim lane, that's sort of where spiritual care and congregations excel, is on issues of purpose and meaning. But should we broaden that? Should we deal with any and all kinds of social determinants of health? And that's something we're looking at together as a group going forward. I'll close with this slide as sort of an aspirational piece. I was really privileged to hear a wonderful healthcare provider named Dr. Laura Perahun. Dr. Perahun is a medical provider in Nicaragua. She and her husband have a clinic that is deeply, deeply, deeply isolated. And I won't go into a lot of their work here, but she was given this lecture, and somebody said, how do you hang on, Dr. Perahun, in the face of difficult times? What gives you hope to keep going? And she said, the people who were working on the artisans and craftsmen who were first working on the Cathedral of Notre Dame knew that as they started working on it, there was no way they were going to see this cathedral built in their lifetime. And she said, if your dreams can be accomplished in one lifetime, maybe you're dreaming too small. And so I sort of have a dream that healthcare and spiritual care is part of that health, care of the mind, body, and spirit, can be a thing of just great beauty in our world, where people aren't suffering from disparities, from healthcare disparities, but have what they need to face the difficulties that come in life. And that may not be a dream that I get to see in this lifetime, but it's one I think we can get towards together. So let me stop sharing my screen there and open this up to questions.
Yeah, so you have to ask your questions through Q&A. You type them in the Q&A section to the right of your screen.
So don't see any yet, and so I'm wide open for comments as well. How many, Maura, how many people in the room? Would it be better to just turn people's mics off and let folks speak? I'm glad to do that.
Okay. Yeah.
So there's a question.
So Jim Bowden asked, is it difficult finding volunteers?
And, it really has not been, Jim. People seem really eager to, and maybe this was also especially during the pandemic, but people seem really eager to want to find a way to to be of use, and this was a way where volunteers could have not a huge commitment of their time, and I think have a strong sense of meaning and purpose out of it. Also say that, we're providing a small, and I didn't make this clear in the talk, we're providing a small grant to many of these churches, not all of them, who we're particularly working with, to provide support for a lead volunteer to do a lot of the work in the congregation to organize things. So I think that has helped make the finding of volunteers much easier.
So Jay, I'm going to try. Yolanda Rose, her hand. I'm going to see if we can get her to be able to speak.
Sure.
Yolanda, did you have a question?
I didn't want to be on the screen.
Oh.
I don't know why I'm on the screen, but can you hear me okay?
Yeah. Hi.
So what I wanted to know, I was trying to type it in the chat, but it was a long question. I have a passion for helping ministry workers and faith leaders engage around data, impacting outcomes for kids and families in Indiana. I work for Indiana Youth Institute, and is it challenging gaining buy-in as to why this type of information is relevant to their congregants, even them having an understanding, like, for example, around being, why being trauma informed matters, why understanding the social determinants of health matters to their congregation ultimately thriving, and the people in it, that are bringing, if you will, worldly problems in some cases. Some churches I found, well, suicide, that doesn't impact us. That's not true, or kids, smoking and vaping, that they're hiding devices in Sunday school just like they do in school. Do you know what I mean? So is that a challenge? Have you found it to be a challenge gaining buy-in?
We haven't yet, but my net has been fairly targeted, not real wide. But I honestly know people seem really very invested in the idea of and maybe it's part of how we frame it, that we're framing that spiritual health includes mental health and physical health. And so you can't, my old boss used to say that in most languages, you can't separate the word faith from health. They're actually both part of the same word. But you know what? I would be glad to talk to you, set up a time offline another time if you're interested, and share experience and share resources. I'd be very glad to do that.
That would be great. Thank you.
So I think
we have another written question. Can you see it?
Yep, I'm very happy to see some of the Black churches involved in this project. It is difficult for some Black people to admit to be lonely or having mental health issues. Thanks for that comment. I have read the literature, and I've had many colleagues and clergy who are African American say that the stigma around mental health or loneliness can be really challenging. But sort of like I'm saying, I said to Yolanda, everybody I've been talking to has among the clergy has said that this is really an important issue. And I wonder how much the pandemic is making that easier for folk to admit. So those are my thoughts, Ms. Carroll. Any other questions or follow up to that? No. Okay. Here you go. I really appreciate that you bring together the connectors on a monthly basis. I imagine that has been quite powerful and a great opportunity to share and support, help keeping connectors. Yeah, thank you. And in fact, we actually have the connectors meet weekly. And so that's, where there was a saying attributed to Mother Teresa, who of Calcutta, who reportedly said to one of her persons working in that terrible poverty, for every hour you spend in the clinic, spend an hour in the garden. And I don't know that that's possible in real life, but we really are trying to live with that here. For every hour you spend listening to others, spend an hour into connection with each other. I will say each of those churches, congregations, has a lead connector, a lead volunteer, and the lead connectors meet monthly to talk about how we can share and grow with each other. Any other questions or feedback? Does anybody have any challenges? Like, why in the world are you guys doing this?
So it looks like somebody put something in the chat, but I can't read it. Who did that chat? Did they put it in Q&A?
Not there yet. I can say that currently all of our congregations are Christian in origin, most Protestant, 2 are Catholic. And we are in conversation with a mosque that we think is about to come on board. And we're hopeful that this is truly a sort of interfaith effort. Nobody asked that question. I thought I'd just volunteer.
Well, we don't go full time. It's kind of up to you, Jay. If there's no more questions.
One more question here, and it is important that I forgot to mention. So somebody asked, how are participants identified, and is it difficult to encourage their involvement? So that's a great question. So we have through the electronic medical system, we're just sort of able to identify persons who are of a certain age, 50 or above, who have a chronic illness and who live in the neighborhoods of one of the congregations that we have identified. And then one of our chaplains just sits down and meets with that individual, and we have a little simple brochure, and it just sort of says, we know you're heading home, and sometimes heading home, especially if you're kind of lonely or isolated, can be really difficult. It could be hard to transition from the hospital home. And would you like someone, one of these companions trained in the congregation down the street from you to contact you? And if so, what they would do is then we'd explain the program to you. And I think that we have lots of people who just say, that sounds great, and just sign right up. And we have some others who say, thanks, but I'm not interested, as you might imagine. I don't actually have numbers on how many say yes and no. I'm thinking anecdotally that it's about 50-50. As the program grows, we think that we'll have a lot of other ways to identify participants, including from our behavioral health clinics, our outpatient clinics, and our elder care programs at IU Health.
Well, Jay, thank you very much for participating tonight. Thank you for all that are attending. I'm not sure why my mic is echoing like that, but I'll have it figured out by tomorrow. So have a good night and see you tomorrow night.
Thanks very much, Maury.